Okay. Hello, everybody. Dr. Sean Orr here from the Neurogenesis Project, and I just want to welcome you in today to our weekly broadcast, which is really turning into more like a monthly thing at this rate. But this is our episode number 4 of the Braincast, which is the podcast of the Neurogenesis Project. Really excited to have you here today. So momentarily, I'll be joined by Dr. Drew Edwards and our friend Dr. Glenn Kolluri. Just wanted to kind of give you an overview of what we're talking about today. We're going to go over our new social media channel that we've created inside the Clubhouse. For those of you who are not aware of Clubhouse, it's a new social media app. So we'll talk about what we're doing with the NeuroNation inside the Clubhouse. And I'm going to talk to you a little bit about how we use that for some Ask Me Anything discussions. So for those of you who are interested in neuroscience and want to have direct access to some neuroscientists, we've got a great collaboration going on with a bunch of really interesting folks inside Clubhouse. We're also going to talk to you today about a paper that came out a couple of years ago, but it's really getting more interest recently on the use of steroid therapy, immunotherapy for people who've had mild traumatic brain injury. And we're going to introduce and welcome Jessica Weed here as well today. She's the head neurological trauma therapist at a place called Balanced Body Center. We're going to talk a little bit about her variety of therapy and how she's making great gains for folks who are struggling with all sorts of injuries, whether they're athletes or other folks. So we'll be very excited to have her join us here in a little while. So waiting for Dr. Edwards to join. Let's bring in Dr. Kolluri here. Glenn, how you doing? Let's unmute you, buddy. There, I'll give you
I'm unmuted. Fantastic. I'm doing good. Thank you, Sean.
Great. Well, while we're waiting for Dr. Edwards to join us, you want to bring us up to speed? I think we've had a really interesting dialogue going on about the COVID brain and what's happening. You're a frontline neurologist. You're in the line of fire. What are you seeing these days?
Every day. Well, there are less COVID cases, but some people are coming in with post-vaccine issues. I don't know yet if there's a correlation, or definitely not a causation yet, but not sure if it's a correlation to see where this problems are. Some things are showing up now 2 to 3 weeks after their vaccine by either manufacturer. So I don't know if they're predisposed. And I read one paper recently saying that people that were exposed to COVID-19 early on now get the vaccine tend to have the complications. So I don't know if that makes a difference.
Interesting. So it's the pandemic really has thrown everybody for a loop, but then it just gets more complicated and complex as time goes on. It's interesting to watch so many changes taking place in the healthcare system, which we probably can save for another time in a deeper discussion. How are things just working functionally in terms of how it affects you day to day as opposed to where we were, let's say, a year and a half ago?
Well, a year and a half ago when we first started with the pandemic, things were pretty quiet. I mean, all the surgeries were canceled. You didn't have a lot of activity. People weren't coming to the hospital. And now as things are coming out, I don't know if we had 2 waves, and now we're getting, I don't know, it feels like there might be a third one coming or something else from complications of vaccinations, but the hospitals are filled right now. The 2 that I'm at, I don't know how it is anywhere else, but the 2 small ones that I'm at, they're pretty much at capacity. But most often people getting the vaccine tend to improve after a day or 2. We just have the little flu-like symptoms before, and then it kind of goes away. Many of them we don't even see.
Well, that's encouraging. So I know when we talked about this with you months ago, it was quite a struggle, and we were getting into the issue of teleneurology and how, really there was almost a need for a remote or hands-off approach just to preserve the resources, neurological resources. Are you still working with teleneurology, or are you?
Teleneurology does cover when I'm not there, but it's a lot more efficient and direct care if you actually have a live person there. Tele can only do so much, especially with inpatient. Tele is great for ER complications and coming in for stroke, but when you need to see or touch the patient or actually do the exam, it's a little harder to do it unless somebody's there on that side to do it.
Gotcha. Can you break it down for us in terms of what proportion of patients you're seeing are coming in with, acute complications from COVID in terms of acute stroke versus
That has
delayed?
dropped off now. That's dropped off from the post, but we've been getting more consults for COVID encephalitis or encephalitis, and they've been on to infection for a couple of weeks, and they're not returning back to their mental status. So there's, we can get imaging. We see some corpus cytotoxic lesions of the corpus callosum that have been identified, and I've seen a couple of those here. The first identified in France. Apparently, there's a paper there. And I saw some here, and so that was kind of interesting. But the ones that are super sick are too sick to even get an MRI. They can't even get down there, from a safety standpoint. When they do, then we can kind of get an evaluation. But I don't know what else to do. Sometimes we can do spinal taps on the patient to check for, COVID in the CSF. That's a new territory that nobody's really breached yet.
So this sounds like it would be a great opportunity to introduce portable MRI to the ICU setting, wouldn't it be?
Perfect. That would be perfect, just to get more information on what's going on. Because right now sometimes we're working in the dark.
I'll go ahead and make sure to put in, for those who are just joining us now, there actually is a portable MRI machine that entered the market, I think about a year ago. I'll see if I can track down the brand of it. It looks like it's designed specifically for the neuro ICU setting. It's heads only. Really, really neat to be able to see that technology finally moving out of the basement and into the clinical setting. So
hoping to have in the ER, they can make a decision about stroke right away.
Yeah, wouldn't it be nice? And it's a disruptive technology for sure. Well, great. So I just got the message Dr. Edwards is going to be joining us momentarily. I think it'd be a neat time to kind of just segue when we're talking about, the COVID brain, to segue into the Clubhouse concept. For those of you out there who are not aware of this, there's a new social media platform out there called Clubhouse, created by Mark Andreessen, one of the Silicon Valley, barons of digital technology. A really neat platform, and we've recently joined Dr. Kolluri, Dr. Edwards, and myself, and we've created a club in Clubhouse called the NeuroNation. And we've had a couple of episodes in there where we bring together various people from the industry, neuroscientists, really kind of a neat interdisciplinary group of folks talking about artificial intelligence, blockchain, disruptive innovation, and it's really exciting. So anybody looking for an invitation to get into Clubhouse, it is by invitation only, and it's a very interesting platform. What do you think about it so far, Glenn?
I'm starting. Thank you for the invitation, and then I was like, okay, what's this? I have to listen. But now I'm listening to it every day, driving to work and driving back. I'm finding some room to come in and enjoy. It's that conversation other than the radio, and then you're actually learning something.
Yeah, it's really interesting. I think it's almost like having just a big conference call. You can have 2 people or 5,000 on there, and really just depends on what you get into. A lot of stuff that probably neither of us has much interested in, but there's some great conversations surrounding neuroscience, cognition, consciousness. You think about it, it's in the Clubhouse. So with the NeuroNation, our goal is to try to bring together people from different backgrounds, physicists, engineers, mathematicians, to this platform to talk about the neuroeconomy. And for those of you who are joining us for the first time, we have defined the neuroeconomy as the post-COVID, post-transformation new reality that we're all emerging into. That for thousands of years we have lived in a cardio economy, and in the cardio economy, people vastly made their living based off of their horsepower, their own ability to lift and move and do things with their physical willpower. Around 2012, we started to migrate into this new environment where more than half of the people on this planet are making their living somehow off of internet-related activities. So you can really have a business sitting in front of your computer and never have to get out of your chair. As long as your heart is still beating enough to give you brain blood flow, that's sufficient to enrich yourself, right?
Exactly.
And so in the NeuroNation, we're trying to capture this idea of what does it mean for a society to go through a massive transformation? You know, if you look at rites of passage, any kind of transformation somebody goes through from a personal perspective, or groups of people going through massive transformation, then what we're finding is that you know, the neuroeconomy is where we're heading. And let's go ahead and bring Dr. Edwards in here, and we can talk a little bit more about that. Hey, Drew.
Hi guys, sorry I had trouble downloading it here.
No problem. Thanks for joining us. You might go ahead and test your volume out there a little bit.
Okay.
There we go. That sounds
better?
good. Yeah, that's a little bit better. Great. So we're just
Kolluri, how are you?
Good. How are you?
Good, thank you.
great. So we're in Braincast number 4 here for the Neurogenesis Project, and we're just talking a little bit about how the Clubhouse is something that we're recently into, and we've taken your name, Drew, the NeuroNation, and put it to work, talking about the neuroeconomy and bringing different people together from different backgrounds. You want to talk a little bit about your experience with it so far, and what you think about that new social media platform?
Well, most of it is what I've learned from you, Dr. Orr, that your ideas of the neuroeconomy, and I wanted to broaden the word economy so it wouldn't intimidate anybody. So I thought NeuroNation would be a great, very inclusive thing. Most people are interested in anything neuro. The decade of the brain ended. Now we're in the century of probably the brain, and Neuralink and all these cool, exciting things that we're going to be able to do. Now the question is, should we do them? And that's a real exciting topic. And as having sharing patients, football players with brain injury and other people with brain disease and addictions, all those things do such damage. And then the whole brain mapping and neuroimaging stuff and the EEG portability and stuff that Dr. Kolluri has been teaching us about. And it's just a real exciting time because we can do things and help patients and expedite their healing in ways we never could before. Teaching us about, and it's just a real exciting time because we can do things and help patients expedite their healing. Was that my echo?
Sorry, user error, glitch on my part. Keep going. You're doing great.
Well, I would just, so that the idea of the NeuroNation, and under that umbrella, we can do all kinds of work in different sort of rooms and meetings under there, and really begin to talk about the principles of helping people heal. You know, brain injury is one of the leading causes of death in the United States if you're under 40. I didn't know that. And it makes sense. And there's a lot of ways that we can injure our brain, but your brain is everything. It's everything. And as we enter this neuroeconomy where we don't have to get paid for lifting bales and bundles anymore and loading them, we're going to get paid for what we can think about and ideas we can do and how we can execute those in a timely fashion. And that requires our frontal cortex to be really online and active. And so I'm just excited about all of this.
No, that's really great. Thanks, Drew. And I think for anybody who's joining us now, we've between the three of us probably have a handful of invitations that we can pass out for anybody who wants to join Clubhouse. Still, it's in the beta test stage, and it is by invitation only. It's really, I've found it to be such a relief. You can get onto Twitter and really get trolled to death. Twitter is one big limbic system of mayhem, in my opinion. And I think a lot of that comes back to the idea that anybody can just send off a verbal bomb and have no accountability for it in Twitter. Same to some degree in Facebook also, I think. But in Clubhouse, when you are part of an identifiable network and you're invited in, I think it changes the dynamic. You have to be responsible for what you say, and you will be held accountable. So I've just been really delighted that the conversations are mature, they're interesting, sophisticated, and that there is, I think, personal responsibility taking place in that medium. So anybody who wants to join in with us, we certainly are looking for folks. We had a really interesting conversation with Dr. Babak Khatib, who's a friend of ours, a neurosurgeon, and very prominent in the brain mapping sphere. Gave him a good opportunity to talk about what he's doing with a good cross-section audience, and I see us just building more interest. Don't you see us building more interest in that environment there? Okay, good.
Dr. Khatib is certainly one of the world leaders in brain mapping. It'd be hard to find someone in neuroscience that doesn't know who he is, and so it's been an exciting thing, and I'm just grateful, Dr. Orr, that you've had a friendship and connection with him for years now, and that's been very nice. You know, he called my sister personally. He didn't know me. She was having some pretty serious brain surgery, and he called her. And he knew the surgeon, and this was at Vanderbilt, and she didn't realize who he was or what he was. And the surgeon almost fell down when he came in to talk to her. He says, "Oh, Dr. Khatib says hello." And he turned to the staff and says, "Oh, we got to do really good here." So
Wow.
he was amazed. I was just amazed at how respected he is. So this is just exciting.
Well, that's great. All right. Well, for anybody who wants, you can connect with us in our social media platforms here on Facebook, LinkedIn, or Twitter, and we'll go ahead and judiciously share out some of those Clubhouse invites. They're actually, people are selling them on eBay right now, which boggles my mind. I was really surprised. Each one seems to be going for anywhere between $500 and $500, depending on where you go shopping. So.
Wow.
It's pretty neat to see a marketplace opening up around that sort of thing.
Where's our 15%? That's what I want.
That's right.
Yeah. I enjoy the Clubhouse.
Yeah.
There's more, so much information was lost in tweeting.
Really?
You know, and tweeting and Facebooking and how you're typing versus the ability to talk and understand your inflection. And that information's presented in Clubhouse.
No, that's true. Yeah, it's a lot more agile than typing it out. Well, along those lines, let's shift gears here a little bit, and we want to introduce this concept of immunotherapy for people who have suffered from excessive sleepiness after traumatic brain injury. Drew, you brought this to my attention, this article. I'm going to post this up here now for those who are watching. Really interesting article that gets into the idea of hypersomnolence, which is excessive sleepiness after traumatic brain injury, specifically minor traumatic brain injury or concussion. And this has some relevance, I think, and was a really interesting article that gets into the idea of the notion that a TBI, even a minor traumatic brain injury, disrupts the blood-brain barrier and opens up the brain to an immune attack by the body. So autoimmune syndromes, which can lead to excessive sleepiness. So Drew, do you want to talk a little bit about why you thought this would be a good article to share with Glenn and me, and how it can be useful?
Number one, I'm experiencing that. As you know, I had a brain injury a couple of years ago, and just how long it's taken the traditional medicine to get me. And then thank God I met you a few years ago, and you walked me through it and got me some help. But you know, the idea of steroids and brain inflammation is not new. But in big studies with severely injured people, you know, the outcomes were mixed. And this was the first study that I was aware of. And I'm not a neurologist as you guys, but so I haven't been looking. But it was a small group of adolescents who had a brain concussion and were experienced depression and difficulty staying awake. And they gave them a infusion. Fairly, I guess a gram is a day is fairly high dose, but at the end of 3 or 4 days, they were in total remittance. They had no, leftover hypersomnolence, and their depression had improved. And a few of them had to come back for a tune-up in 6 months, but other than that, they were basically fixed. And that just caught my eye, and I sent it to Glenn, and Glenn says, "Well, is it your cousin, Glenn, or your
niece?" My cousin's a sleep specialist, pediatric sleep specialist in California. So
I'll hand it off to you. I'll hand it off to you here.
Yeah, I'm waiting for her to text me back after she reads it. So I'll curious to see what she says.
What are your thoughts?
It was fascinating to me that trauma, and this can expand to traumatic brain injury or stroke trauma or wherever you want to call it, opens up the blood-brain barrier. Kind of knew that, but then starting off with an autoimmune inflammatory with anti-GAD antibodies and voltage gain and potassium channel antibodies, that was different. That's a new, I didn't realize that. So using the steroids, which we say the same dose that they do for MS patients that have an MS attack, is probably where they got it from. And sealing the blood-brain barrier and then averting the neuroinflammation. Maybe that's a pathway. Just my guess right now.
Yeah, that's a really great take on it, Glenn. I think that I remember having a conversation about 10 years ago with a researcher at the Scripps Institute here in Florida. We have a Scripps headquarters is over there in La Jolla, California, but we've got a great Scripps Institute around Palm Beach, Florida. And he had worked out this really neat microarray where he had literally millions of protein epitopes or protein targets on a grid, and would wash this grid with cerebrospinal fluid, and was really surprised to find that patients with Alzheimer's disease in their cerebrospinal fluid were expressing something like 50 or 60 antibodies towards brain-oriented proteins. And so compared to somebody without Alzheimer's disease who didn't have that same kind of expression.
Wow.
Really got me thinking about the implications for what is floating inside of our cerebrospinal fluid and how does that impact our brain function. And
are much of these going to be considered or changing the pathway to thinking that these are autoimmune responses?
So that, Well, I think even just the discovery of the glymphatic system, back around 2014. Now it's hard to believe it's been 7 years that we've known that there's this alternative clearance mechanism for cerebrospinal fluid in the brain, glial cells that create these small tubules that surround the venules called the glymphatic system, which only turns on during sleep. So it turns out that we've got enough brain energy to be doing and thinking things, or to be clearing out the byproducts of our activities, which are usually the byproducts of oxidative metabolism, beta amyloid, tau proteins, the things that accumulate in our brain, which turn out to be not good for brain function. So it looks like in traumatic brain injury, not only do we see disruption of the blood-brain barrier, we see axonal shearing and damage to the insulating covering of axons, but we also see disruption of the glymphatic system. So it really is a wholesale, wide-spectrum, systematic disruption of neuronal function that takes place with even mild traumatic brain injuries and concussions. So to have something that would help to reverse that effect. Obviously, stimulant medications are frequently used, right? But from the perspective of reducing inflammation and potentially healing up the blood-brain barrier, allowing homeostasis to restore, this is a very interesting signal, I think, in this paper, particularly when you look at the autoimmune aspects of it.
So somebody that has maybe obstructive sleep apnea never turns on their glymphatic system then.
So can you imagine that vicious cycle that people get into, right?
Sleep a little few minutes, and how long does it take to turn on the glymphatic system? How long do you get stuff? And then these things accumulate, and then they get brain injury. Right. Yep. And I thought another interesting element of this paper here. So there are 3 autoantibodies that were discussed. One was the anti-glutamic acid decarboxylase. And for those of you who are interested, GAD, or glutamic acid decarboxylase, is the enzyme that's the rate limiting step for the conversion of glutamate to GABA. So the 2 most abundant neurotransmitters in the brain, glutamate is excitatory and GABA is inhibitory. They're in balance with each other. Very beautiful design. Glutamic acid decarboxylase antibodies interfere with brain function, and it seems like there's an overaccumulation of glutamate and a deficiency of GABA. So we see those antibodies in certain conditions like stiff person syndrome, for example. And what do we do for them? We do immunotherapy. We get rid of the antibodies and brain function improves. I thought it was interesting also, if you different subtype of GAD, but in type 1 diabetes mellitus, we've known for a while that it's an autoimmune disorder.
And children who have type 1 diabetes actually develop autoantibodies against GAD as well, the GAD65 flavor of GAD. So seems like there's interesting opportunities for immunotherapy here. And
just popping up in my head, I mean, if we're using steroids for COVID-19 pulmonary infections, maybe going up to 1 gram a day for CNS injury from
COVID.
All these autoimmune things are happening with other diseases. Could it be happening with COVID brain?
Great point. And in fact, in our first Clubhouse NeuroNation meeting, we actually, talking with Dr. Khatib, had the really interesting discussion around what is going on in the brain in people who are affected by coronavirus, SARS-CoV-2. Turns out that brain mapping using PET scanning is showing us that people who have the neuroinvasive, CNS invasive form of this, who lose their sense of smell, find that the virus tracks back along the orbital frontal cortex into the temporal lobes, the brainstem, the cerebellum, and get a very particular heightened state of anxiety, hyperadrenergic outflow, sympathomimetic changes that take place. So we're thinking that maybe some of the secondary effects of coronavirus really are neurally mediated, right?
Yeah, I'm believing that, yes.
So, you know, it's opening up a lot of different targets probably to immunotherapy, not only immunotherapy, but neuromodulation, and like to see how that all pans out in the long run. Yeah, very exciting. For those who are interested also, I know I'm commenting the conversation here, but there's a great book called Brain on Fire that came out about a decade ago also. Have you guys read this book?
I heard about it. I didn't read it yet.
Really interesting first-person account of a young lady who's a journalist, lived in Manhattan, and started developing, classic symptoms of encephalopathy: confusion, disorientation, seizures. She saw a neurologist who made the diagnosis of, overuse of alcohol, which didn't make sense. She wasn't a heavy drinker. She got worse, deteriorated. To make a long story short, ended up in a hospital in New York City and was correctly diagnosed with the Anti-Nmda receptor antibody syndrome. So another autoimmune disorder, which is pointed out in this article that we posted here, N-methyl deaspartate is a receptor for calcium to enter the brain. And so it turns out that she had developed this autoimmune syndrome because she had an ovarian mass, and her immune system was trying to get rid of this mass and was cross-reacting with the brain. So great book. I'll put that as well in the comments section. So
this reminds me of I had 2 patients that I had MS, and one of them had COVID. I could not give her steroids because she had a reaction, but I gave her IVIG, and within a day she got so much better. The other MS patient had to give her steroids while she was having COVID, but I gave her 1 gram a day for an MS exacerbation, and she bounced back from a respiratory standpoint faster than the others, now that I think about it.
So I was really excited a few years ago when the Green Journal of Neurology came out with an immunology variant on the journal, because we're just seeing so many instances in which the immune system is involved in neuropathology. I guess in a way it's maybe not surprising when you consider how our food supply seems to have been deteriorating. There are just more pollutants in the air, more pollens than ever. A lot of things to stimulate our immune system.
Agreed.
So definitely a lot of food for thought. It makes me think that it would be neat to have a Clubhouse or a podcast with a neuroimmunologist on here soon.
We wrote an article on sort of the trauma in children, trauma and drama, and the cumulative effect on that. And the evidence seems to be pointing that sustained emotional trauma can also provoke some of these responses, perhaps autoimmune disease. And you think of, back to your point a minute ago, Dr. Orr, after we were talking to Dr. Khatib, the symptoms he was describing, these sort of result of glutamate overload. We give them GABA supplement. We give them benzos basically, or alcohol. Or people naturally self-medicate with those things. So we're onto something here with the GABA system and the the glutamate system being out of whack, and it probably gets imbalanced in more ways than we ever imagined. And the availability, of course, alcohol is a anxiolytic, and we call Xanax freeze-dried alcohol. You know, when we treat addicts, it works almost identically, other than the hangover. But it's amazing how, and I've known a patient that, you know, we consulted on a couple of years ago who, you know, went through a lot of emotional drama and trauma and the death of a spouse, and the physician was giving her up to 5 milligrams of Xanax a day, and then she went cold turkey, almost killed herself. Wow. She had this glutamate storm, and she ended up being hospitalized and nearly died. But it took several months, and I think, you know, we got her on B12 and magnesium and all the good things, and that helped, had an immediate effect on her, and she's continued to improve. But there's a lot to learn, because I think sometimes we're not knowing this at the primary care level is really can do some damage to people if we don't understand the balance of the neurotransmitters and the neurology of this.
Those are great points, Drew. Thanks. And, you know, I think it is kind of a shame that there's a big gap between what we know from a basic science standpoint and then a clinical application standpoint. Something as simple as magnesium can make an enormous difference for people who are, you know, going through withdrawal or suffering, you know, any form of muscle spasticity. When we know that magnesium is an allosteric modifier, which means it changes the receptor for the NMDA receptor, it actually blocks calcium from influxing into the cell. It's a very powerful tool, and it's cheap and it's easy to use, and it has a low toxicity. You know, I think there are many tricks of the trade that we can apply to these folks, and it'd be nice to be able to spread those, especially in this era where, you know, our system seems to be so shaky and people just don't have access the way that they used to. So, but thanks for bringing up that trauma paper. I'll put a link up there for those who are interested to read more about our perception of you know, trauma and brain function. I think that's a good segue to introduce Jessica Weed here, who we're going to bring in. Jessica is the head neurological trauma therapist. She's a licensed massage therapist and has her certificate in personal training, and she works at the Balanced Body Center in Claremont, Florida. We've got, hey Jessica, welcome to the group.
Hi everyone. How's everybody doing?
Thanks for
good.
Great. Thanks for joining us today. It's great to have you here. I think I was very interested in what you're doing and thought it would be great to bring you on today. We're always interested in looking at strategies to improve brain function and like to learn more. So we thought we'd give you an opportunity today to talk about what you do at the Balanced Body Center and what a neurological trauma therapist does. Go ahead and inform us.
Yes, Sean, thank you so much for letting me come on here and just have the opportunity to speak. So I do a multitude of different things. Basically, it's functional neurology. I have different certifications that I basically infuse to each other. So one of the first ones that I started with was NKT. It's called Neurokinetic Therapy. And this is basically the pathways. So basically a muscle assimile, and this muscle actually works for that muscle, and there's a pathway problem. The brain doesn't have connection to it. It's disconnected from that muscle, so it uses this other muscle to get to it. That's the first one. Then I got thrown into PDTR, which is Proprioceptive Deep Tendon Reflex. That one deals with more receptor-based cranial nerves, primitive reflexes, peripheral nerves. I mean, all sorts of, you're talking about 90% of the nervous system. I mean, it's a huge number. And then there's IRT, which is injury release technique, which just deals with the talus and what's happening to the talus when basically there's any sort of trauma at all. And then I do have other certs in, like, it's called IKN, Integrated Kinetic Neurology, just dealing with like basic concussions, retraining the vestibular system, the visual system. I mean, all of that goes together. So there's a lot that I just wrap all in a ball and give it to people.
Well, I really admire your ambition and your enthusiasm for what you do. It's really infectious, and I've taken some time to watch your videos online and how you work with people, and it's clear that you are very involved. Years ago, when I was first thinking of getting into neurology, I was advised to go and this is back in early college days, to do a rotation with a physical therapist, and went to Health South, and I was so sorry, Health South is no longer with us, but I was very uninspired to see that, most of the people who are showing up are being put on machines and given free rein to go and do all the kind of conditioning themselves. Didn't really see much hands-on kind of work, but you're very involved with people. So why the difference?
So this type of therapy is more neurological testing, while as the PT side of things is more like strength. So they give you, exercises for A, B, C, D muscles, and they're all in the same group. Let's say you have a shoulder problem. So you strengthen all the rotator cuff muscles. When really what I do is I figure out who is the weakest link and why he's the weakest link or why he's not functioning or performing. And I reset that within the brain through the reflexes. Most times. Other times it could be a breathing drill. Other times it could be an actual exercise with certain things. A lot of times it can be a position. There are these things called event positions, and think of like a motorcycle accident where somebody gets thrown through the air, and it's not actually being thrown through the air is the trauma. It's when they land and come to. It's the area where they first felt the pain. And that ends up being a really huge playmaker in anything with like bodybuilders, like deadlifts, bench press, anything that's going to be bilateral, a squat, a lunge. Lots of positions like that can be just overused, so they get dysfunctional and cause pain.
So thank you again. I've looked a lot of your stuff too, and I think I reached out to you on LinkedIn.
Yes, Dr.
I'm very impressed. And when you talk about the weakest link, or I assume you mean in a muscle that's not firing, and then trying to reestablish a connection. Can you talk more about the disconnect, and then how you reestablish connections again? How do you help the patient do that? Because they don't think I'm going to reconnect this muscle, that muscle. You have to go in and do something, I assume, right?
Right. Yes. No, of course. So what I do is basically I perform manual muscle testing. I get my information as to see who is functioning and who is not functioning. Basically, there's something called a neural lock, and every muscle is supposed to fire in a neural lock. And if it doesn't, then that usually means that there is a pathway problem like NKT, or there could be a receptor problem with PDTR, which means the sensory information that's being delivered to the brain from that site or that muscle is either incorrect, dysfunctional, aberrant, it's just not reading correctly. But that could be because of a multitude of reasons. It could be just your central nervous system threshold. Sometimes, so I deal with cranial nerves. So a lot of times it's not even a muscle, it's the cranial nerve that's shutting down this drop down, this funnel of things, ligaments, organs, emotions, muscles. And then that leads to this extra trauma usually. Sometimes it can be a concussion, right? Like you bump your head on, I don't know, the trunk of your car or something, like just because you're out of that threshold.
So when you talk about a cranial nerve, give me an example of a cranial nerve and the dysfunction that it caused, and how you were able to help that person regain that connection. That would be very helpful. Let's personalize this a little bit.
So I just dealt with a autistic kid who has Asperger's. He's 20 years old, and basically he had a optic nerve dysfunction. So by manual muscle testing, I have a way to a protocol to figure out which way the light. I actually use my iPhone right here, the light, to shine it in his eye. I mean, sometimes I can also do an anti-stim if they don't like the light or if the light is too sensitive. But basically, I see which direction it is, and then we actually can use a breathing pattern to reset the cranial nerve, which is really cool, whether it could be like Kussmaul's hyperventilations or Shane Stokes or things like that. And then most of the time, it's actually a receptor-driven dysfunction. It's not actually the cranial nerve that is dysfunctional. It's actually being driven by a receptor somewhere on the head, usually the head, neck, face, or cranium, and which usually implies some type of impact, concussion, MTBI, something along those lines.
Did this Asperger's person have an injury, or you were just improving his?
We were just improving. Yeah, he didn't even have an injury.
Okay.
However, I'm sorry.
So you were treating his Asperger's and found that dysfunction with his.
We were just searching around to check. We were just doing a protocol cranial nerve check, and it came up where his right eye only lasted 1 second to the light. And then there was his left eye that lasted 4 seconds to the light. And now these cranial nerves are supposed to be lasting at least a minute in daily life for at least your threshold to function, right? Like if you walk outside and you only last 1 second to the light, like your eyes are immediately watering or you're super sensitive, you get a headache, something of the sort. What we did was an actual breathing pattern for him, reset it, and a couple days I gave him homework to basically, because it was 1 second, I basically told him he has a bright bathroom that he complained about. Every time he walked into the bathroom, he got a headache. And I said, "Is your bathroom really bright?" And he said, "Yeah." And I said, "Okay, so your homework is to walk into the bathroom, turn on the light, turn it off, and walk out." Now, before that is his real homework, where he has to elevator down his central nervous system threshold, which is just literally sitting in a quiet, dark room where there's no light, and if there is light, then he can cover his eyes. And he's supposed to do that every hour on the hour. It could be every 30 minutes if he wanted to. It's just about how much he can withstand, like his nervous system before he fries. That's how we retrain it.
So you're kind of flooding him and hoping that his photophobia would improve through having him develop a tolerance to it then.
Correct. Just like we would train a muscle in the gym, we are neurally conditioning him to basically we're telling the nerve to constantly wake up because it's really tired and it wants to not work or wants somebody else to work for it.
Thank you.
Yes.
This is really interesting. So go ahead, Glenn.
Oh, I just had an interesting question or observation. I'm a big fan of yoga. I don't do it very well, but a lot of this sounds like a neurological. You have got found and discovered neurological pathways to some of the yoga techniques that the people do. Is there any overlap, or are there two separate things?
I actually have treated quite a few yoga teachers, yoga people. Positions are, that's who it is. It's positions with yoga and bodybuilders, the people who have tons and tons of patterns, but they're in so much pain and they don't know why. It's because they literally just have these positions that have been overworked and basically have become traumatized because they're overworked. Even though they might feel great when they do it, or they might feel great after, or maybe bad during and maybe bad after. I mean, it depends on them, but yes, it definitely relates to positions. I treat a lot of those.
Gotcha. Thank you.
This puts me in mind, Jessica, of EMDR, eye movement dissociation reprocessing. Have you had any experience with that as a therapeutic modality?
Yes, Sean, I have. I actually, so I got treated myself.
Hmm.
I am not a big fan of it, only because I don't know, just as a personal preference, like it's not my thing. But I will say that in PDTR we have the 5 distinct eye movements, and saccades is one of them. So I can see how it plays a part, and I can see where its spot is. It's just not my personal preference.
So I guess we've developed an experience with it in people who are suffering from PTSD and really had great results with it. I'm curious about who's your target demographic? Who do you usually work with as clients?
Lately I've been heading more towards the TBI, the concussions, the autism, Asperger's, Tourette's, things like that. Just because I'm more fascinated with the neurodevelopmental issues that come with it, especially with like primitive reflexes. It's insane. But I mean, it's really for anyone. It's anyone who has a brain, really. Like, I mean, it's I've done it on dogs. I've done it on horses. It's pretty fascinating. I definitely, if I had my choice, I would choose athletes, I think. But at the end of the day, athletes are athletes because they want to compensate and they want to win and they want to push themselves. I need more of the person who has had the traumatic brain injury. They need to take it slow. We need to do, certain things in order to require them to go ahead, if that makes sense.
So you're focused really kind of on the rescue recovery side of things, rather than dealing with somebody who's optimized and pushing for a higher level of function.
Yes.
Is that just your personal preference, or most people who are doing this kind of therapy follow your lead in that way?
I mean, I've dealt with both where, we want the bodybuilder who has more function, or we need the athlete to have more function if it's a combat athlete or something. I think that my personal preference would be the TBI, that kind of stuff, because just myself, I've had concussions, and I mean, you guys were talking about the excessive sleepiness, and I just started laughing because I was like, like, I remember that. And that's where I want to make an impact at, because I think that just resonates with me more than anything.
This is really great. So as neurological MDs, when we go through our training, when we're focused on things like neuroplasticity and receptors, we have our own nomenclature, which sounds similar to some of the things you're talking about, but I think you mean things in a way that's different from the way that we mean things. How do you communicate, and do you get referrals from physicians? What's your normal referral pattern, and how do you interact with people who are in our industry?
So I've had quite a few meetings with doctors. Sometimes they go well and sometimes they don't. I have gone into multiple neurology places. I've gone in to just show and, hey, do you want to see what I do? And gotten completely like turned down before, like, get out. And then I've gotten the, wow, come back here. This is really interesting. Let's have a chat. I get some referrals from doctors. I get some referrals from chiros mostly. I'm in business in partnership with a massage therapist, so we kind of trade clients back and forth. However, there's it's a lady who used to own a building in Winter Park for autistic kids. I'm in relationship with her, and she sends me the Asperger's, Tourette's, the developmental issues, those kind of people. And then really it's just word of mouth. I mean, I haven't done, I maybe just started marketing on, as you can see, I just got on LinkedIn. I just started trying to get more content out because people don't know about it. So, I want to have that video when the doctor asked me versus not having anything a long time ago and just being like, let me, they don't have time, or, they're busy, or you need to schedule an appointment, which I totally understand. But this way it's quick, it's easy, and get in, get out. If they want it, they want it. If not, they'll let you know.
Well, I congratulate you on your marketing efforts. It's an interesting environment to be working in these days.
For sure. Social media.
I think from our perspective, we're driven by results. We like to embrace therapies and strategies that get our patients functional and optimized as fast as possible. And so I think we're generally more open-minded maybe than most. But, as you can see, we're constantly learning new things just to discover that brain injury itself can elucidate an autoimmune reaction that can lead to excessive sleepiness is new news for us, although intuitively it makes sense.
Right.
So very interesting. So what's the best place for people I put your links up here for LinkedIn and Facebook. What's the best place for people to find you?
That would be Instagram, really, or LinkedIn. It is the J_RAWW13 on Instagram. I am looking there is a Facebook page. It's Balanced Body Center, Florida, FL.
Okay.
And I think that's about it. Yeah.
Jessica,
Not too huge social media.
I had a question. Do you have any experience or interest in doing stroke patients?
Oh, I actually do have experience with a stroke patient. Yes, those are very fun. We got somebody who had a mini CVA, and basically the left side of his body was just not functioning, couldn't even lift it. I mean, he would try, and obviously the other side of his body would try to come help. It actually went back to it was a frontal lobe emotional dysfunction that I've only done 2, and the other one kind of discontinued. There was other problems, but the one that I did, he came back online, and he actually plays tennis now, like with that side. Yeah.
Great.
Fantastic. Nice.
Yes.
When I was going through my neurological training as a stroke neurologist, I happened to work at University of Alabama at Birmingham, which is where Ed Taub worked. And Dr. Taub was probably the foremost researcher in helping us to understand neuroplasticity. He devised the concept of constraint-induced therapy, or CIT, which limits the useful limb and forces the affected limb in a stroke to stand up and start to do the work again. So we owe a huge debt of gratitude to Dr. Taub. And if anybody's interested in reading more about that, The Brain That Changes Itself by Norman Doidge is a great book to check out. So I'll put that in the links as well. But what you're doing works on that platform. So it's really interesting to see how this has grown and flourished in your environment, and congratulate you. Any last concepts or words you'd like to leave us with before we wrap up here today?
Just thank you for the opportunity to let me come on here and speak about what I do. I appreciate it. Thank you for your time. And that's really it.
All right, Jessica, great. Thanks again.
And touch.
Yeah.
Yes, thank you guys so much.
All right.
I appreciate it.
Thank you.
Thank you very much.
Interesting stuff. So, really neat to see how neuroplasticity is being leveraged here as a business model, and how younger folks are taking it to a different level. What do you guys think?
Beginning of the neuroeconomy, starting all over.
That's right. Great.
I was thinking as she was talking, the exact thing you just talked about, the restraining the arm, the good arm or leg, and then forcing them to use the other one. And basically, it's like the black box. The outside of a lot of people was they regained function, but exactly how that happened, how those things reconnected is still, has that been elucidated, Dr. Orr, Dr. Kolluri?
I think it's like a child having to learn how to talk or walk, and they're just forced to. When you have a stroke, there's nothing wrong with the arm. completely normal. It's just all the wiring. So now you're getting that forced wiring to reoccur, and rerouting is how I explain it to patients. So when they want to move the arm and they have to desire to move the arm, then the brain says, oh, I need to compensate, and then start rerouting around the stroke damage part.
I remember when Dr. Taub was first starting to work with our patients at UAB, we were serving up some of the most damaged folks to him because what we were doing was innovating in the stroke environment. So people who normally would have died survived, but then many of them were left with catastrophic deficits, and it was really a challenge to figure out how to rehab these folks to a point where they could function again. And it was interesting to watch at first how constraint-induced therapy, I think it took a while for Dr. Taub and company to iterate the right kind of protocols, and it was very scientifically driven, and eventually it got to the point where I think they figured out faster and faster ways to help folks get better. Kind of seems like Jessica here with Balanced Body Florida's figured out a way to take that to the next level. So it's exciting stuff.
Exactly.
So I'll leave links in our comment section below for anybody who wants to learn more. So I think we're getting kind of to the end here. Any other news that you guys feel like sharing from your own worlds and the neurogenesis side of things before we wrap?
I think, as I've introduced you to the work of Dr. Bloom and Dr. Gold and some of their work with reward deficiency and the GARS tested that we've adopted a lot of that. And I was reading the new draft of an article he had just written, and my question was, and he works a lot with addiction, and that's been a lot of my background, but my question was, and maybe this is a whole other topic we should do on pain, and she was just touching on that, but I wanted to know if someone was on long-term opioid therapy for irretractable pain, that nothing else would work, would that cause epigenetic changes in the GARS test? And I just sent him the question. What do you think about that?
Wow, that's a really interesting question. I was just reading about.
It's.
Well, if you get into glutamic acid decarboxylase, there is interesting literature around epigenetics and the expression of GAD and the NMDA receptor also. In fact, I think there's probably even more written about epigenetic influences, especially methylation. But in regards to GAD, it turns out that it seems like in schizophrenia, for example, in a bipolar disorder, there's a downregulation of GAD in the frontal lobes, especially the prefrontal cortex. And so again, we're looking at an upregulation or an increase in abundance of glutamate and a loss of balance between glutamate and GABA. And it's something as simple as the methylome, which is another level of control over the genome, can maybe have an influence over that. It's kind of controversial. I don't think it's a settled thing by a long shot. There's a lot of research that needs to be done. But you're asking a really good question there, Drew. And I think that we need more research. That's always the answer to everything, right? We need more research, but
right.
It
we
certainly
see that we call it just the neuroadaptation in addiction, where they downregulate dopamine 2 receptors in the frontal cortex from cocaine. And so, is that a genetic expression eventually, or is that just a direct result? Or that mechanism, I think, is very interesting to me because the test would be to do GARS testing on a whole bunch of people and follow them for 30, 40 years and see which ones developed addiction, and did that change then, the genetic expression exchange. But the mechanism, I think, is what we're all looking for, is how does this stuff occur, and how then could we mediate it, to help people recover from these devastation, whether it's disease or injury to the brain. And so it's a good discussion, and we should have a segment on pain from a neurological standpoint. That would be incredible.
Absolutely.
We need to get Dr. Bloomer-Gold on the show.
That'd be great.
Yeah. How about you, Glenn? Do you have any topics you'd like to suggest for future shows?
Not off the top of my head right now. Just, more interesting stuff on the vaccine and what I'm seeing in the hospital, whether the relationship to post-vaccine is causing or unmasking neurological.
Really?
Worse. I'm keeping track of stuff. I don't know if it's going to go anywhere or what's going to come up to. It has no relationship, but I have no idea where it's going to go. So every day there's at least 2 or 3 people coming in from each hospital that have had the vaccine within 2 to 4 days to 2 weeks and having some complication that's new to them.
I think it would really be great to talk about that. It's such a political hot potato. If you think about where we've been, it is a messy kind of area. But honestly, I think that just demands more reasoned, well thought out discussions between people of different opinions that to where we can actually come to a kind of consensus, so we can get past the politics of this, because in my opinion, politics is ruining medicine along with pretty much every other sector in society. But good, great. Well, good topics. Thank you, folks. Appreciate you, gentlemen.
Thank you.
It's great to have Jessica Weed on here with us tonight. And for those who are interested, well, I'll put links below. Please like, subscribe, and share. That's the way you can help us to support the channel and get the word out there, what we're doing with the Neurogenesis Project, and look forward to doing Braincast number 5, hopefully very soon. All right. Thanks very much for joining us, everybody.
Thank you.
Take care.
Yeah.
Bye.